Thanks, Laura. I'll just warn you up front, it's not me. It's so it's really a pleasure to be able to participate with you all today. I remember when Will started this quite a number of years ago. It was this small community in Mendocino County, and now it's this burgeoning community, really, and conference that it's in its 7th year. So congratulations to Will and the other folks who started with him. But it's really an amazing grassroots effort that keeps on trucking. I want to talk from both a policy, at least a policy advisor kind of a role, but also from the user, the internists, the PCPs, the physicians, the clinicians of the world, and really speak of high tech really as a transformative public policy. I think this kind of activity is one example, but even in an organization, we've been using an EHR since 1999, so of course that predates high tech. It has helped us achieve our goals. So this is the kind of story I want to talk about. And so 2 things. One is one of the things I do is chair the Meaningful Use Work Group of the HIT Policy Committee. So that's some of the major ways I spend my time nowadays. And we're looking beyond stage 1, look a little bit behind the scenes in how we're processing this information, what's the goals, and some of the criteria we use to try to make recommendations to the government. So HIT Policy Committee is a FACA committee, a federal advisory committee, so we make recommendations. The government can choose to listen or not. The track record has been we've had a truly close collaboration with both ONC and CMS in the whole high-tech programs, and there are many of them, as you know. The second part I want to talk about is the quality measure, which I think is the hidden gem that's going to help us drive our clinical performance. So the first is just to remind you, as Claudia did, this is something that the HIT Policy Committee and all of its work groups and volunteers keep in front of them all the time. High tech, as you know, was passed before ACA, so it was in 2009, but it was designed as part of that rider with the stimulus bill to enable health reform, because that was President Obama's agenda. This is a true enabler of that. So looking behind the scenes, and as I say, I sort of view this as transformative public policy. I think most of the organizations, I think clearly the organizations we represent, view this EHR as very enabling for that. And then not knowing that the true reform was to come and to stay. So this is an indispensable part of that. This might be the most famous slide that I've ever created. So this was from the Meaningful Use Work Group. Back in 2009, we put together the framework, or the recommendation for the framework, in 6 weeks, because unlike many of the statutory milestones, ONC, HHS has really been following this very closely. It's remarkable. If you think of HIPAA, which was passed in 1996, and the privacy rule came out in 2003, this has been really right on schedule. So we were thinking that at that time, we knew that from the latest, in fact, it came out of David Blumenthal's work, the latest survey showed that about 3% of ambulatory care practices had, quote, comprehensive EHR systems. So we're really starting from 0 and trying to take the whole country to 60. So we knew we couldn't do it all at once. So we divided it into 3 stages, at least for at that time, 2015, stage 3, and thought, first of all, let's get people on board with data in structured format to the extent possible. Then by stage 2, we were imagining passing it around in a safe and authorized way. And stage 3, we were going to hit the measure and improve outcomes. So far, I think we're doing that. Claudia talked a lot about stage 2, and I'll cover some of that as part of this talk. The four basic principles in achieving meaningful use and getting your payment were these. They seem simple and innocuous, but as you know, there actually is a lot built in and a lot of value built in as well. So the first was certified EHR, and you might have thought of it initially, as I did, it was sort of like a UL certification, that this won't electrocute you, but it turned out to be a surprisingly potent lever to essentially affect all vendors across the country at once. So all the things that we could not as customers get our vendors to do, all of a sudden they had to do. So that was a bit of a pleasant surprise, and it turned out the model is raise the tide and float all the boats. So you got to be careful how fast you raise the tide, But that was the model, and it turned out to be, as you know, very driving for both the vendors and for us as providers. But so that's a powerful lever that was underappreciated initially. Meaningful use, we are all familiar with. The exchange of health data was another one of those things that we all asked our vendors to do, and nobody would do it even for another customer of theirs. And all of a sudden, it's becoming a reality because of the work that's going on here and the work that Claudia alluded to in the Office of National Coordinator. And the fourth one is the hidden gem, as I say. It's causing us to be able to transform the health system, and I'll talk more about that in the second part. The other thing I wanted to mention, though, is the law does allow, and there's the assumption by everyone that I know is that there is life after stage 3. So in a sense, there's no predetermined end to, quote, meaningful use. So as you know, after 2014, beginning 2015, there are penalties phases. There's a penalty phase, and you have to meet the increasing requirements as determined by the Secretary. So there's no predetermined end to meaningful use or high tech. So the 5 categories, 4 are clinical or health related and 1 is foundational, was part of that initial framework. And probably the couple that I'm most proud of, I think, in terms of being part of that process is number 2, which is the engaged patients and families. Everybody would have assumed number 1, improve the quality, safety, efficiency of healthcare. We added give us the tools to reduce healthcare disparities, not just complain about them. But the second initially was thought to be a, quote, EHR adoption or incentive program, and we turned that into an EHR plus. If we're going to have this in electronic form, we darn well better be sharing it with patients and truly engaging them. And you're seeing as the stages roll out, that's becoming a reality. Then the third one is really what this whole group is about. Not that HIE is not part of everything else, but clearly we can't get coordination if we can't get the data around. So that may be one of the hardest things in terms of what was available in 2009 or even available in 2012, but we're still pushing on that to make it really happen. And I think there's a big change in this direction. So early results, and I'll just give a few slides because probably some of this has gone before, but you can see this inflection point that's just really obvious. Now this is at the end of the first year, which ended in February of this year, and you can see how many people really shot for that gold in a sense. And that we have 250,000 providers already registered in the program. That half of the hospitals have already been paid, and 1 out of 5 physicians and other providers that qualify in Medicare and Medicaid have already received their check. That's a tremendous success compared to the 3% statistic that I quoted you in 2009. And one of the concerns is that most of these systems, and it's true, address primary care more effectively than they do specialty, but yet actually more than half of the folks receiving their checks have been specialists. So there are challenges in getting the criteria set to cover all specialties, but it looks like a lot of people are already in the game. Close to $6 billion, and may have already reached $6 billion, have already been dispensed. Now that's a big number. It may be small compared to 2.8 trillion, but compared to what was devoted in the United States prior to high tech, which is about $50 million a year, this is enormous amount of money, which is, of course, why we have this activity and why most of the practices and hospitals in the country are at least paying attention to this. So let me just talk a little bit about what's after stage 1. As you know, we're expecting the final rule towards the end of summer, and so we've already been working on stage 3 recommendations, and I want to just shed some light on that. So talk a little bit about stage 2 NPRM as a sort of branch point, a jumping off point. The first thing I want to share with you is some of the criteria that the advisory group and all of its work groups use in order to try to make recommendations to HHS. So one is it's got to support the new model of healthcare. So if you remember, this legislation was to enable health reform, not the political health reform, but health reform that we have to do to meet the deadline of we're running out of money. The Medicare Trust Fund goes bankrupt in 2024. So the new model includes team-based care, outcomes-oriented, population management. The things that we want to put into these EHR systems have to support that kind of model of care. So that's one of the visors that we use in coming up with some of these recommendations, as well as sort of pruning them. The second piece is that we don't set, sometimes some of the members think they do, but we don't set the priorities for the country. The secretary does. What we are trying to do is have the systems in place so that we as providers can honor those priorities for the country. So we try to track the National Quality Strategy, Million Hearts, some of the programs that were mentioned earlier. The other piece is this whole thing of writing, quote, writing rules for the country is pretty daunting. So we'd like to have the criteria be broadly applicable, not only to primary care, but to specialty care, not only to folks with heart disease or diabetes, but broadly all of the kinds of health issues, including wellness or well-being, that consumers, residents in this country have. And finally, all areas of the country, rural, urban, and otherwise. So we have a lot of that, of course, in California. We really have a diverse state, both in terms of the geography, in terms of the ethnicity, in terms of language. So this is a good benchmark in terms of the rest of the country. Fourth piece is not to chase things that are already done. So not to chase measures that are already topped out, meaning we've already gotten there, and that are not already being driven by the market. The market has a good way of encouraging innovation. Where we want to pick up the pieces is where, like we talked about in care coordination, where the market wasn't delivering the goods. That's where we want to focus our attention on. And finally, it sort of does no good to create yet more silos of data. We need to operate in areas where the standards are mature and would be expected to be adopted for stage 3 by 2016. So these are some of the criteria we're trying to apply to say, of all the things we could be doing, which things should we recommend to HHS? The other principle, the underlying, the guidelines we're using, or the philosophy we're using, in terms of using meaningful use, one, it's as a floor, so it's not the ceiling. And two, we want to use these criteria or objectives as exemplars. So if there's some kind of functionality, being able to apply clinical decision support, we want to put that, cause that functionality to be in the systems, but we're not going to enumerate all the kinds of decision support that you could have. We are going to use as exemplars things that target national health priorities. So that's how we do these things, to not be comprehensive, but target functions that need to be in the systems in order to allow us to do our work. The second piece is you only have to go so far. Once you get, I'll just pick a round number that I use, is 30%, then the market, the people, the organizations are going to behave that way from 30 to 90%. We don't have to keep pushing, because the further you go up, let's say you go to 90%, all of a sudden all the exceptions, all the reasons why it's not possible, you bump into, and that causes a lot of unnecessary pain. Once people are at 30% or 50%, they're not going to stop or turn off things. So that's another sort of assumption by which that we use in terms of determining what's the threshold and how far to push. So with that, let me just go a little bit, pick up some comments on some of the NPRM stage 2 and talk about sort of directions we're going. So the first lever we're using, we started out with this menu option as one way to give flexibility by at the same time programming some of these things in the EHR. So the expectation then is if there's a menu in one stage, then in future stages it'll become core. So that gives people a heads up. People, that means developers and that means providers, because both of us need heads up on this. So we're still using that philosophy where it doesn't apply to everyone, but we want to give a strong signal. We use the word a lot. Signals is trying to give advance notice without the final rule so that people can start thinking about these things and even working on these things. Some vendors have already picked up on some of these signals and just start development ahead of time. And that's, I think, a smart thing to do considering the track record. Second piece to emphasize is, you know, CPOE, the HIT Policy Committee originally recommended CPOE for all orders, got a lot of pushback, so stopped at meds in stage 1, and so we're coming back with lab, rad, and referrals for stage 2. That was our recommendation, and that was also in for the NPRM. The other piece is clinical decision support. As you know, CDS and CPOE are probably the lion's share of where we get the benefits out of these systems. So one way, in stage 1, we talked about use one rule. Well, that's pretty limiting, actually, and what we wanted to do when we recommended for stage 2 is to come up with attributes about what things would support decision-making by the provider, and let innovation decide what to apply for this group of docs in this community. And that was the way that the NPRM came out, and we'll have to all wait to see what happens in the final rule. But that's the way to both raise the floor, but also allow flexibility and innovation. So that's a method that we used there. Claudia, the next part is problems, meds, allergies, and family history. Images is important because we heard a lot about that, a lot of requests from the specialists in particular, specialists who use imaging. So we included that in our recommendations and was included in the NPRM. One of the things I'll just mention about problems, meds, and allergies, the NPRM had them sort of taken out as separate objectives and put into the summary of care, thinking that that's one more consolidated way of approaching it. We recommended back that we suggested keeping it at a top level objectives. And here's our thinking. Those are clearly key data that's important, that every physician uses in the EHR, and you would love to have it complete and accurate. And we want to work harder on the functions provided by the EHR to make it complete and accurate. And of course, HIE and reconciliation is part of that. So what we're eventually shooting for in stage 3 and beyond is, are there ways, and there are ways, that an EHR can help remind or even possibly pre-populate in some cases like BMI, problems in the problem list, and help us keep the medication list accurate. So those are going to be key drivers both for care as well as clinical decision support, and it's our intent to keep adding functions of the EHR to support that direction. We keep pushing on advanced directive. We push to have it included for eligible providers. It didn't come in the NPRM. We pushed again. We've been pushing since stage 1 on this because we think it is so important. It is what patients want to do. They need help in getting us to honor their wishes towards the end of life. And one of the first things that gets in the way is not even knowing whether it exists, let alone having access to it. So we are continuing, that's the policy committee, trying to push for that to happen. Next is the patient and family engagement. Now, Claudia talked a lot about this. So view, download, and transmit is a new kind of function of sort of liberating the data and getting it to more places in a standardized format. So we're pushing on that, including secure messaging. So that's becoming standard practice in many areas, like the areas that John and I practice, but it's not in all areas, but it's one of those things that really should be the standard of practice throughout the country. And this is one way of raising the floor or raising the tide on that one. In care coordination, as you know, that's not there yet, certainly not in all places in the country, and we're trying to attach some pieces of information, standardized pieces of information, to be carried from one place to another. Now, we like the concept of summary of care record, and we like the concept of a shared care plan to everyone participating in care, including the patients and their caregivers. The only thing we ran into was no common definition for that. So nurses, for example, know very well what a care plan is. Doctors never get trained on what a care plan is. We sort of had this concept, but concepts can't be reduced to standards. So that turns out to be one of the biggest challenges we have, and really we're hoping the professional associations will act on that challenge. But so we started with what seemed to be basics, which is how about goals, how about instructions, and how about care team? Rapidly got to the point where it's just not possible, care team. So we said, how about just PCP, if that exists? And so that's where our recommendation stopped, just because that's where sort of the community is, but we definitely want to push that further. And this is probably one of the organizations that can help us get those standards created, get the structure defined, and then help us get the information around so that we can accept it, and then the next stage, of course, is reconciling it. Because we have in mind reconciling not only, just like we reconcile meds, but not every place, probably just in the hospital, we'd like to reconcile other information like problems and allergies and include the patient with that. Public health is another one of those areas we're trying to push on. Unfortunately, the statute did not provide any extra funding to public health departments at the same time, but there is some work in that area going on. Yet the public health departments were really grateful that we made this a category, because it gives them a head start, because now our systems are going to have the ability to transfer to the public health departments. And then finally, in the foundational category, we added encryption of data at rest, because as you know, the #1 news report is something stolen. And it's really alarming or frightening that to this day, we have devices that are stolen that are unencrypted. So that's something, what we've done, all we're doing is piggyback on HIPAA, but the information is that people are still to this day not complying with HIPAA. And so we've just upped the ante, so this is another reason to comply with HIPAA. In other words, you won't get your meaningful use dollar if you don't. The final rule for stage 2 is expected to come out later this summer. And our target and our goal is to get the final rule of stage 3 out as early as possible. We're shooting for, we're trying to help HHS to hit 2.5 years ahead of time, because both the vendors and the providers would like as much advance notice as possible. So we are trying to make our final recommendations available by May of 2013, which is a stretch. So let me go further on the hidden gem, the quality measure side, and talk about how that, one example is how that is being used to drive our care transformation. So as you know, there was in statute a request from Congress that HHS measure the quality of health care every year. And they've been doing that, I think, for close to 10 years. So if you look year to year, unfortunately, we've been improving about 2% per year. In this graph I'm showing, it's 1.4%. It's been revised more recently to like 2.4%, but that's still not going to get us to where we need to go. So the question that pops into my mind is, are we measuring the right things? If we really knew what if we were measuring the right things, it seems like we would be moving more quickly than that. So if you look at it, how did we get the measures we currently have? We did that by first saying, well, gosh, what data is out there? And then we said, well, of the data out there, what's standardized so that I could compare? And then once I had that list, I said, what quality goals could I set around that data? And then what can you do with that? To me, it sounds like a hammer problem, a hammer looking for a nail. So the data that you know that was out there, and still the one that's out there most commonly now, are claims data, administrative data. And every provider in the room knows that that just is not reflective of real life. So clearly, the garbage in, garbage out principle, that's not going to give you measures that the provider, the people you're trying to influence, are going to believe. They're not going to chase it. So a number of years ago, there was a CMS program called DOQ, Doctor Office Quality, and the thought was to say, gosh, if people are starting to implement EHRs now, why don't we get data from that and use that to drive our quality measures, which seemed like a great idea. So signed up for that program, and then my disappointment was that they gave us the definitions from the old claims-based world. So in a sense, we were going to extract claims from our electronic health record system. So after delivering on those, delivering the results as requested, I said, can we do another study and say, what if we used clinical data from the EHR to put out measures? What would happen? So this is the study we did then. The idea was here was the methods. We looked for people with diabetes and looked them up using 3 different methods. One method I'll call the gold standard, which is a human read the chart and says, does this person have diabetes? That's the only question he asked. That seems like a pretty easy thing to do, and we call that the gold standard. The next method was to say, use the claims-based definition of whether a person has diabetes. Now, in the claims world, you say, well, that's easy. You just say, did I get a claim for diabetes? Then you think another millisecond, you say, well, gosh, how many times do you code diabetes when you order a fasting glucose because you're checking for whether they do or do not have diabetes? I said, well, I got a fix for that. I'll require 2 claims for diabetes within the reporting period. So you can see how you start trying to fudge with what you got to try to approximate the right answer. And the third way we used was to query the EHR with whatever data exists in structured format and determine whether this person has diabetes, so without a human intervention. So those are the 3 ways. And then apply the measures, the DOQ measures, to those. Well, it turns out that if you just looked at structured information in the EHR, 98% of the time, you could match the gold standard. In fact, if you just looked at the problem list, 94% with high sensitivity and specificity at the time, you could get the right answer. So without human labor, you could get the right answer 94% of the time. The problem is if you apply the current existing quality measure definition, the one we're getting paid pay for performance on, you would miss 25% of the diabetics in this case. We also looked at CAD and you'd miss 30% of those. And when you miss those, which means they're not in your denominator, half the time your score is going to be different, statistically significantly different. So what do I mean by that? What's the consequence? Well, in one of the measures, A1C management for diabetes, if you use the administratively defined measure, we'd score 97%, which of course is an A+. The only problem is it's not humanly possible. Do you think that for 1,000 doctors or 500 primary care, they have kept up to date with 97% of the diabetics on their whole panel? It's sort of not, the clinicians would not believe that. And on the other hand, if you look at the people that we missed, the 25% that we missed because of administrative definition, you'd score 68%. So what's the difference between 97% and 68%? It's the difference between an A+ and a whatever, a C, a D, whatever it is. The implications of that change in definition using claims-based versus using clinical data are significant. Claims-based world, you're going to underestimate your target population. Why? Because we required you to have 2 times, have billed for, let's say, diabetes twice during that reporting period. So you basically are only going to count the people you are seeing and you're really working on. You see how that works? And what happens is that ups your score because it becomes a self-fulfilling prophecy. On the EHR side, you're going to more likely accurately define your denominator, accurately define your panel with diabetics. Your score is probably going to be lower for the reasons I just told you. Now, the problem with having the disparity of scores, it might look pretty good because everybody's getting A+, but we won't be solving the problem, which is how do we take better care of our diabetics? And interestingly, in the new world, when you're being measured on population, the community you're serving, you're not going to do very well. So not knowing the truth means you're not going to do very well. The other piece is if you're only using billing data, and many clinicians don't even see that, there's a lot of gaming that can go on. I'm hoping that, and I don't believe that will happen in the clinical record because there's a lot more at stake. You're not going to game the clinical record to fulfill these scores, I don't think. Or maybe I don't hope, or I hope. So what if we turned it around and said, what's the most important quality goals we could have to address the nation's health priorities? Then look for the data needed to measure those quality goals, measure against those quality goals, make them standardized, and make them exist in EHRs, which in a sense is a bit of the levers that we have with meaningful use. So can we first set the health priorities and then chase after it by capturing the right data and reporting the right thing? So the beauty is when you do that, humans, and doctors is one example, like to do well, especially when you're in a service in a caring profession. And when you put in front of their face data that's credible to them, you'll chase after the better score. When you put in something that they don't believe, nothing happens, which is what I just showed you. So in a sense, this is a, quote, free way of helping us all do better with our jobs. That's the power, that's what I'm saying. One, it's the power of the EHR, but if we fix the quality measures to match that. So in a sense, the $27 billion, which is almost 3 orders of magnitude from what we used to have, is still a tail wagging a big dog of $2.8 trillion. But it's been, as you all know, really potent at doing that, because it raises the bar for the EHR products, it accelerates the provider change, and it's helping us reshape the quality measures if we help do that. It will not help to computerize yesterday's quality measures. So right now, we as professionals and people working in the quality measure space, you know, going through the NQF process, need to change it and need to have de novo new measures. That care coordination, the HIE, which is the subject of this conference, the subject of all your activities, combined with these new quality measures, I think is really going to give us a tool to transform the care that we deliver. So finally, I think by saying that, it's saying the planets are finally aligned. We have the brick wall, the 24, we have the tools that are being placed, and we have some of the measures, and we have the great people in this room. So I'm hoping we all do great things. So thanks so much for your attention.